Good morning, everyone, and welcome to this panel discussion session on strengthening universal health coverage through digitalization, which is hosted by the Robert Bosch Foundation. My name is Mujahid Sheikh, and I am Professor of Health Governance at the Hertie School in Berlin. This session today is on UHC, as you may have read. If you think about the progress we've been making with UHC, we were at a UHC index of 45.8 in 1990, and in 2019, we moved up to about 60. However, despite this progress made, it is very unevenly distributed across the world. So it is as high as 95 in Japan and as low as 25 in Somalia. At the same time, the pandemic is undoing the gains we made in UHC and has probably halted progress as well. We have, during the pandemic, observed that countries are more willing to adopt digital technologies to address the needs arising due to the pandemic. So both have been happening at the same time, and it seems like we are basically making a lot of progress towards UHC, but also adopting digital technologies to help us reach to those targets outlined in the SDGs. This panel today, as I said, is on strengthening UHC speakers who come from different country perspectives. To introduce the speakers, we have Francesca Colombo from the OECD, who's the head of the health division over there. We have Nanjira Sambuli, who's the vice president and co-chair. We have Njide Ndili, who's joining us here today in person, who is the country director of Farm Access Foundation. Online, we have two speakers. We have Eileen Tuzil, who's the country manager of Pfizer in Germany, and we have Kiran Anandampille, who's the advisor to the National Health Authority in India on digital health strategies. Without further ado, just to outline sort of what this session is going to be like, each speaker will have about 8 to 10 minutes to make their opening statements, and we will then take questions or comment suggestions from the audience, and probably also from the other speakers if they have any. So it's more like a discussion, and then the next speaker will be invited to the stage. So Francesca, would you like to go up first then?
Sure, I'm more than happy. Hello, good morning, everybody, or depending on where you are in the world, good afternoon, good evening. Let me start by a little bit of setting the scene. I mean, first, when we talk about universal health coverage, a very important issue is that this is not about just access to services, but obviously access to services which are delivered to the highest standards of quality, of safety, of effectiveness, and of people-centeredness. And I think when we think about the opportunities that digital solutions, technologies, and digitalization offer, it's not just in terms of facilitating greater access to services, but also in facilitating the improvements in the quality, in the people-centeredness, in the safety and effectiveness of care. So just if we want to think of a framework for how digitalizations can be transformative of a healthcare system, and that will be my first part of the talk, that digitalization can be really transformative, but that in most countries, at least the OECD countries that I represent, there's still a lot of gaps that remain to be made, and the process still lags behind. So if we're not really that much along an income, a national income frame that we need to look at, even within high-income countries, you find more or less digitally skilled health systems. But broadly, if we look at the role of digitalization, I think there are many important ways that digitalization can be transformative of a health system. And the first one is really improving the clinical decision making and the clinical care in the health services. So think about having much more precision or even faster access to information for the clinicians, the possibility of using data analytics to. There are immense barriers in terms of leveraging the power of data for the broader health system benefits, which I mentioned. So the research, for example, the surveillance, even the people-centeredness, the clinical optimizations and improvements. And those are linked to the fact that data remain very much in silos. So, you know, in that individual hospital, in that individual primary care unit, you know, maybe the pharmacy data bank and so forth, but remain very much just there in a very fragmented functional level to leverage the power of big data, but also to understand the pathway of a patient. And that's
and especially even for the administrative side, but also for patient side. And then, you know, the data that is then generated from our healthcare service seeking can be used to draw out meta-analyses that help us better understand trends, including even predictive elements on what could be the next wave of a particular virus or that kind of thing. And really to help in that way to help support preventive health solutions. We've seen a lot of movement also around wearables, and those have been purported to help with detection on monitoring of vitals through smartphones and more intimate devices like watches and rings and that kind of thing. I think another really important area is obviously in health and information literacy more broadly. Despite what we've seen, and sometimes it's almost like it's all either doom and gloom and something else, we have seen that these have been vital tools to help disseminate accurate information real time and really release the flow of information so that, you know, healthcare is not seen as this thing that's a siloed ivory tower element, but that also allows for citizen participation and querying as concerns arise. I must mention that just after this, we'll be launching the Lancet and Financial Times Commission report on governing digital health futures, in which we really did lay out many more scenarios around how digital technologies and data can be used to improve healthcare. So please join us for that and do pick up the report to look into that more. So let me move to the next element that was around transformations we're observing regarding digital infrastructure, uptake and readiness during this pandemic, and what needs to be kept and carried forward, which I thought was really interesting as a question. And similarly, what have been the main roadblocks so far? So we've seen that digitalization, we've entered the decade, if you will, of digitalization, and the pandemic has necessitated that, not just in healthcare, but also in how we worked for those of us who could transition to remote kind of work or virtual working, for education, and so on and so forth. In that process, in developing and developed countries alike, we've seen, for example, a huge uptick in cloud infrastructure to enable sharing of data around this pandemic and its movements in different countries. So it really has turbocharged something that maybe different countries were still thinking is down the line, and many have been forced to adopt as quickly as possible. Telemedicine was also mentioned and has been a useful stopgap measure in many places where, again, the infrastructure was available. But one thing that should be made clear now, and if there were any people who doubted it, is that digital divides are very real, and they manifest between the connected and unconnected, but also the different levels of access between those who are connected. And it's really, really important as we talk about the digital divide to remember it's actually divides, and they take multiple forms. They take access forms, they take gendered forms in terms of social cultural norms, skills, and others. So really seeing the complexity across the board. This is not just a developing country issue, we've seen it across the board. And this is important because one of the other main goals to help us achieve universal healthcare in 2030 through digital tools is actually goal 5 of the Sustainable Development Goals that talks about access to ICTs, but for least developed countries by 2030, and the trajectory has not been very promising even before the pandemic. So this really helps us understand that before we talk about digital healthcare, we have to talk about the digitalization process that needs to be happening in communities to enable healthcare to ride off of that and actually drive us towards digital health futures. And these roadblocks are usually not discussed yet in the health sector the way they have been in other sectors, like in information and communication. So it's really, really important to take a wider view on what are the digital determinants or the transformational elements that will enable us to adopt digital health. So it's even as something as access to electricity, reliable electricity in some parts of the world. It's what other infrastructure needs to be able. It's even something like whether there are safe public spaces to enable me to get to a healthcare center and so on and so forth. So when we talk about the determinants of digital, is not just the availability of an app or AI or the next flashy thing from the lab. It's really also what are the elements in this particular society that will help this be adopted, or what other elements need to be worked on in lockstep to finance the infrastructure to enable this kind of environment where digital technologies can be used. For healthcare and digital literacy then, or even literacy in itself comes in there, and skilling. This goes both on the supply side in terms of healthcare professionals and also for citizens. And so when we talk about these kinds of things, we really do need to take that whole of society approach. So the kinds of interventions we all design can work, they're interoperable. So we're all not just focusing on getting more phones in the hands of patients, but we have not thought about the healthcare workforce and so on and so forth. So that's sort of like the kinds of transformations we're seeing, a lot of which we need to keep, but we need to keep it to the context that it's highly unequal. In many cases, it's still unjust, and that we need to take a wider lens in how we're talking about the digital determinants. Lastly, there's a question about the knowledge that digitally strong health systems can share with digitally weaker systems, and the support that the former can offer the latter. And the first thoughts that came to mind was, really, is there any digitally strong system? And Francesca's confirmed that as well. I think everybody's figuring it out. And the big thing I think for me is there really isn't going to necessarily be a one size model fits all approach. It's really about what are the appropriate sustainable ways to introduce digital technologies in different settings to actually support healthcare provision. Now, you might find in one part of the world, community health models are the way to actually advance healthcare. So what literacy looks like there is vastly different from what it might look like in another context that has a more, say, urban setting, individualized kind of approach. And as I said, the antecedents of what determines digitalization are often overlooked, including who's able to design these technologies, including which contexts inform what is being designed as digital health solutions. So even for those who consider themselves strong, one of the biggest things they can do in this ecosystem is acknowledge that what has worked for you is just an example, present it with the humility to know that this is just sharing the knowledge of what we've done, and going beyond just saying we introduced the tech and that was it, boom, it's really about what kind of trust in the society is there, what kind of investment has been happening in your healthcare system before digital technologies were introduced, so that people actually do trust that they can go to a healthcare institution and get accurate, reliable information. Here's something like even the gender differentials in how we access healthcare. Today, even many women will tell you, you go to a doctor and explain your symptoms, right? And you're probably likely to be dismissed. If that is encoded in how we introduce digital tools in that, what does that tell us? And what does it tell us when most of the designers of these technologies are not the same women who are supposed to be accessing healthcare through that? So those are just some of the things that we need to keep thinking about. And I want to just conclude by saying, again, it comes back to supporting appropriate, contextual, and sustainable approaches to digitalization. There's always a talk about scale, which I find quite problematic because it really implies this one size fits all. But if we take rather a sustainable approach, what we're saying is, what works for one community, what works for another community? Let's build scale as this interoperability of systems that work in different contexts, as opposed to trying to impose what works in the OECD to the G77, for example. Those kinds of digital development approaches should not be introduced into health the way they've run in other sectors like information and communications, because health is not just another sector to disrupt with the tech mentality. It's a very intricate socioeconomic, social-cultural system, and we cannot afford to approach the move fast and break things approach, or impose what works in one context in another. So if we start getting those building blocks right, even in how we converse about the role of digitalization and digital tech, we get the humility to understand that it's fast and slow. It's not all doom and gloom. We go beyond the dichotomies that it's all good or all bad, and we start to find out what's appropriate and how involve the communities that are supposed to be served in this. And then maybe there's a chance that we get it right.
Thank you very much. Thanks a lot. Two very interesting points that you made. One was, and Francesca also sort of alluded to that, is there's a social gradient in digital literacy, and we need to acknowledge that, and it is real. There is a digital divide. Having said that, the other point is that policymakers often try to impose digital technologies without realizing that the very basic infrastructure necessary to utilize those technologies is missing. Something like electricity. It is such a basic thing necessary to be able to charge your laptops, to charge your phones, and to use digital technologies. That's often missing in villages in so many countries. So what would you think policymakers should consider before they even move up to this higher level of handing out phones and handing out laptops to people? What is necessary?
Increasingly, I'm convinced that even before we ask what the role of policymakers is what is the role of the knowledge systems that inform what policymakers pay attention to? If policymakers are at the World Health Summit right now, and many of the sessions are just posing innovation as great, and that's the only knowledge source they're going with. That's why you'll end up with somebody running off to introduce old, reused. We've all donated our old iPhones and we take them to a village that doesn't have reliable electricity. That's because the information sources that we present are still trying to hype up this world that will be all utopic using these technologies. So I think it's an upstream problem as well. We need to, and especially in digital health, we need to pause for every promise the likely pitfall, because health is not an area you can afford to have unintended consequences. That's our lives, that's our bodies. So how we frame those issues is very important to temper what's coming from the innovation side of things in digital more broadly, that's trying to show that this future, and you see it in a lot of the kind of reporting on what digital can do. If we temper that, especially in a sector like health, then policymakers are interacting with the information that is more nuanced. And then, that challenges them to realize, okay, it's not just as easy as a plug and play solution. If we start correcting for that, and especially in the sort of international development, international finance assistance space, we can start having more realistic proposals and plans. It's not that it's wrong for a government anywhere in the world right now, in at least developed country, to think that they want to introduce those laptops and those computers. They just have to calibrate for what are the determinants of that. And it shouldn't be a shameful thing to do, because everybody's hyping up how AI and I don't know, the metaverse is going to help with healthcare when you're not ready for that. So it really is, I'm challenging actually all of us who inform policymakers to take on a more nuanced approach, so that it's not about policymaking by pressure to look like you're not left behind with a hype, but you actually calibrate it for what's relevant and what's actually appropriate.
Thank you very much. While we have questions, we'll see if we have any questions online from the audience. But if you all have any questions for the speakers thus far, then please feel free to just raise your hand. If not, then I will move on to our next speaker, which is Njide Ndili.
Well, thank you so much. I think Nigeria did a lot of justice to that topic. I think I want to look at it from a different perspective, putting it in boxes. When we talk about universal health coverage and the use of digital, we have to, first of all, determine what is universal health coverage. First of all, there's the access side of things, demand side financing. Then there's the supply side, which is actually getting good care when you're going to the healthcare facility. There's the patient, the behavioral change, and the communication, the way they actually seek care. Then on top of that, you have the governance. Unfortunately, when you look at lower middle income countries, there are quite a bit of pillars that are missing. So if I have to discuss this around the pillars, first of all, how can digital help to accelerate access? So you look at the demand side, which is, can people actually afford to pay for healthcare? And what are those tools that we can use to aggregate funding, aggregate finance, and so on? So that's a huge pillar that is really the starting point. Because if you look at it, I'll take Nigeria as an example. Nigeria is a country of over 200 million people. The percentage of people that have access to any kind of healthcare coverage is less than 5% of the population, which means that less than 5%, if they fall ill, most likely will experience a catastrophic event. Now, of this 200 million, less than 60, well, I would say about 60% actually lives on less than $2 a day. Okay, so first, these are serious pillars that affect universal health coverage. Then you now begin to ask yourself, how can you use the mobile device to aggregate funding? If you come to Africa, Africa is full of developmental partners with so many different kinds of programs that are being run in silos, in parallel, roll back malaria, stop TB, global fund for TB, HIV, AIDS, and so on and so forth. Is there a way to use the digital or mobile technology to aggregate this funding such that it can stimulate the users or those who can't afford to pay to actually access healthcare services? So that's one big pot where digitization can actually help, or mobile technology. We have to, again, separate digital technology, mobile technology, and its use in Africa, because Africa, as you know, has one of the highest adoption of mobile technology in the world right now. So there's a lot that can be done on that sphere. So that's for demand side financing. Now, when you look at the supply side, what can be done within the healthcare facilities? You talked about digital transformation within the supply side, but if you step back and look at a lot of the healthcare facilities in Africa, they actually still have manual processes. So you have to decide or determine, there's a progression from manual to digitization, which is actually changing the process, the paper process, into an electronic form such that you can actually get data out of it. Then digitalization, which is now the entire system going, you come in and you're able to pass through the system using digital technology. Then the digital transformation itself is when it centers around the patient, like Uber and the likes, where you can control the use of your data. So you look at a lot of low and middle income countries, and we're very far. In fact, we're stuck between manual and digitization. So if digital transformation is going to happen, there needs to be a lot of effort into digitization, which is transforming the paper processes into a digital format. That way, there's a bit of connectivity between the different stakeholders such that that digital transformation can happen. And that is slowly happening on the supply side. And interestingly, there's a lot of innovation happening on that space, be the rudimentary telemedicine and the rest of it to the artificial intelligence and so on. But how do we make sure that they're streamlined and that those on the demand side are able to access those services such that there's a link between that? Then you move over to the governance. You talked about regulation, and I know that especially for low and middle income countries, those that are making the regulations, the laws, the policies are so way behind on the innovation. You know that private sector oftentimes is the one leading in terms of innovation, in terms of putting out new ideas that could enable access to healthcare. But how can a regulator regulate what they don't know? So we talk about digital literacy. Digital literacy actually has to go all the way to the regulator so that they can understand and be able to make informed decisions about the kinds of policies that can accelerate universal health coverage. Now, all this is tied in together using this platform of digital, and there is a huge potential to accelerate UHC using either the mobile or digital technology. Now, I'll just throw out some statistics. In Nigeria, as an example, there are 151 million active phone lines. If you put that in context, that's a country of over 200 million, and a lot of the adults have mobile phones, be it feature phones or smartphones. It doesn't really matter, but the fact remains that they have a tool that can help enable access. Some innovation which we were involved in that is happening in Kenya, especially layered onto the mobile money, is M-TIBA. M-TIBA, for those who don't know, is a mobile health wallet. So you can actually put money in your wallet, and it's ring-fenced just for healthcare services. And you can actually direct you to a specific provider that has been accredited such that you can now manage the demand side financing. You can, at least put some kind of oversight on the kind of care that is being delivered. So you're creating a virtuous circle around what would have been a vicious circle. First of all, they can't access care. Then, they're going to the hospital and there's, you can't even evaluate the kind of care that is being given. So this is just examples of what digital can do. Then I'll also give another example of one of the tools that we have deployed, which is the poverty mapping tool. So based on the support that we normally give to state governments in Nigeria, pushing towards UHC, we realize, again, because of the poverty levels, that government has to bear a huge burden of paying the premium or funding or supporting those who cannot afford to pay. So how do you determine who cannot afford to pay? We normally say when we run a pilot program just to, to test this paradigm of demand side stimulating stimulating demand side financing. We saw a lot of people that because it was a low cost insurance program, people were driving in with Mercedes-Benzes and buying this insurance, but it wasn't meant for them. So we had to devise a way to be able to screen out those who could really not afford to pay, the indigents, using a poverty mapping tool, which is a mobile device. And it's based on an algorithm, asks you a series of questions, and depending on your responses, it grades you as eligible for subsidy, or you can afford to pay yourself. So again, once you're identified as an indigent, then automatically you are registered onto a health insurance scheme. Again, this is a way to close the loop from end to end, starting from the individual, demand side financing, identifying who is poor, who is eligible to pay, going into the facility and determining the kind of care that you can receive. And of course, on the back of all this is tremendous amount of data, which you can then use to determine the quality of care that can be given. You can use it to determine the availability of medicines, drugs, what area, and there's so much you can do with it. What is most important is that with especially the mobile phone, what incremental cost of reaching the next patient is just very minimal, such that you can really accelerate. So how can we begin to look at ways of leapfrogging what is going on in Africa, to the next level? How can we, bring the regulators on board to understand the potential of mobile technology such that their policies are favorable? And then lastly, just to end on the note that when we talk about the developmental partners and support from the developed countries in terms of how can they support the low and middle income countries or that are less digital, can we focus a bit more on, like you talked about, the infrastructure? I often call it the Maslow's hierarchy of digitization. Is the electricity there? Is the cost of data affordable? By the way, Africa has one of the highest cost of data in the world, yet a huge percentage of the population is not connected. Is there a way to count people, make them visible before they are connected? I often say in a lot of my talks that we talk about Nigeria being over 200 million. I was never counted. My 4 children were not counted. So if we're talking about leaving no one behind using digital technology, how are we sure that we have counted everybody that is within your region? So again, counted, visible, connected. How do we make sure the infrastructure is there? How do we make sure there's digital literacy? People understand what they do with this phone. How do we align the world, the developmental partners, behind the country-led initiatives, country regulations, so that we support the country's priorities towards adoption of technology for universal health coverage. So I'll end at that.
Thank you very much. So what is very interesting, I think, that I found in what you said is about sort of the supply and demand side, meeting in a way. Often I think, and I think, correct me, Francesca, if I'm wrong, in OECD countries or in high-income countries, people pose the demand side as a problem in, data governance and data regulation, because we're very concerned about what is happening with our data. And we are at a level over here where we can talk about those problems, because in the Maslow's hierarchy, this digital hierarchy, the other basic needs are fulfilled. And then we can talk about higher level things like, is my data in the right hands and what is happening with it? What is the sort of the demand side response to the availability of technology? Are people concerned about sharing their data in Nigeria or in Africa broadly?
Well, I think there are two schools of thought. First of all, there are those who are really educated, who have the smartphones, who know what is going on. They're really connected, and they are the ones who are concerned about where's my data going and who is using it. Then you have the lower level, the people that actually need the care, who really would sell their data just for care, who are part of schemes that are funded by donors who own the data. So at that point, they are really not, all they need is care. They're not concerned where their data is going, which is why, Nigeria talked about the report that we are launching, the Lancet report. We have to take those people into consideration, even though they're not aware of the data that they are producing. It's our responsibility to educate them and protect them, their privacy of their data, the use of their data, even though we're talking about data solidarity, using the data for public good, but the generator of the data is the owner of the data and has a right to give consent on what their data is being used for. So there are two extreme ends: those that really don't want their data going anywhere, and those who don't even know they're producing data. Really, they just give me the service. I don't care what you do with it, and so on. So I think that it's a huge divide that we have to find a way to bridge. And again, I think the responsibility lies on the government. Because oftentimes, the data is in private sector as well. It's not just in the public domain. So how do we ensure that there's appropriate governance structures around the data that's being generated? So that really will come out a lot in the Lancet report, which is going to be launched in another hour or so. Yeah.
Mm-hmm. So again, it's very interesting that you mentioned that people are even willing to sell the data just to achieve basic care.
Yep.
And that just shows how tied in digitalization and data is with universal health coverage. So if you ensure universal health coverage, there's going to be an automatic uptake of and better understanding of digital technologies and how best we can use them.
Yep.
Thanks. Our next speaker is Kiran Anandampillai, who's the advisor to the National Health Authority in India. Kiran, over to you.
Yeah, hi, Moja. Can you hear me?
Yeah.
All right. Thanks, and good morning, everyone. So I think fascinating conversation hearing the other speakers, and I'd like to just kind of continue on the whole topic we ended with, which is health data and how are people viewing health data. So I'm going to just tell you a bit about what India is doing in that space, and of course the initiative is very new in India. India is of course not anywhere close to UHC, but there's been significant efforts in that space, at least moving, I would say, slowly in that direction. So there's a very large initiative in primary healthcare where the government is trying to set up almost 150,000 health and wellness centers, almost one for every 5,000 people that will provide primary care. And all of that's supposed to use quite a bit of digital technology in its delivery. The second is a program that covers inpatient care for almost 600 million people who are below the poverty line. That's called the Ayushman Bharat PMJAY. And of course, the health benefit packages has its own limits in terms of what it offers in terms of inpatient care, but it is far better than I think what India had in the past. But just in the last year, in fact, right after the pandemic started, India also kind of went on launched a new thing, and that's called the Ayushman Bharat Digital Mission. So they actually have created a new digital initiative with the primary intent to actually solve the problem of how health data is being available, A, to every citizen or the patient, and B, also to the policymakers and the ecosystem. So in, so to speak, to try to create like a common set of rails on which we can enable both of them. So the core idea of the Ayushman Bharat Digital Mission, and I'll just use the word mission going forward to keep it short, is to essentially create what we call as digital building blocks for healthcare. And the question really becomes, when you're taking a national or a nationwide approach, can you really come up with what would be digital building blocks that will be enablers for healthcare? And I think that's really what India is attempting to do. There has been quite a few papers published on it. Of course, the thought process started back in 2018, but really it was when the pandemic started. And I think the whole pressure on saying, hey, we need better digital systems really came to the forefront in the government, that the government actually triggered the implementation of the mission. Now, the COVID pandemic itself was very, very eye-opening for India because, suddenly the whole population was demanding information on, hey, how many cases are out there? What's really happening? The fear factors were really high. And what was fascinating to watch was the number of new IT systems. India is well known for its IT globally. And I think we saw humongous contribution from society and people, and a whole bunch of new national systems actually sprung up. We have a system where every COVID test is actually tracked now. We have a system where, of course, every vaccination is tracked. We have a system actually for oxygen supply from, being produced in steel mills, being moved to various hospitals. We have a digital system for that. We have a new digital system that came up for every hospital admission for COVID and so on. So, while it was wonderful because, as policymakers, as the health ministry started getting a lot more information, they started relying on information from these systems. It was also very obvious that you're going to have this only for COVID. What happens, for the rest of the digital system. So in many ways, the mission, the National Digital Health Mission or the Ayushman Bharat Digital Mission was really created to say, hey, while this is good that we have nice short-term solutions for COVID, what can we do from really a long-term perspective and kind of laying the rails for India? And so it launched actually on August 15th, 2020. So last year, right in the middle of the pandemic, it was in a pilot phase for the last 1 year, and just recently kind of went out of the pilot phase into a national thing. The idea is actually quite simple, and the idea is to kind of solve or say, how can we create certain public goods, so digital public goods that can be used by any participant in the health ecosystem. They could be private participants, like a private healthcare provider, from a small hospital, clinic to a diagnostic chain, or a public system, the primary care centers or the district hospitals, or even large programs like India's Mother and Child program or the NCD program or even the vaccination program. So all of these entities we see as essentially anybody who's treating a patient who is creating or holding on to health data as a potential participant who needs to join the mission. And the idea the mission says is, hey, if you are holding a health data for any resident, you need to start sharing it with the resident, and you need to do that using a kind of a set of standards or APIs and open standards and formats that the mission is prescribing. And the way the idea really here is to start by getting every citizen to be able to build their longitudinal health record. So as more and more of these entities start to participate, we are looking to make sure that everybody gets their health records, and it doesn't matter where they're going for care, whether it's into the public ecosystem or into the private ecosystem. The second part is to use exactly, and the beauty of the architecture is that once you have, in our system, we call it a health ID, and we say that, okay, you have a bunch of health records linked with your health ID. And you essentially use something called a federated architecture. The government is not creating any kind of a large central data store for this information. So it actually continues to stay spread across all of these various healthcare providers who created it, so to speak. But it really enables the resident now to use their data for better care for themselves. So, they can walk up to a new facility. There's a way by which they can actually share it with their facility with their consent. There are ways in which they can actually share it with an insurer or even a mobile phone app, say, which maybe wants to help you better track your NCD. So essentially, it's about helping democratize your health information for your own benefit, but keeping it under the user's control. And none of this data is visible to the government or to any other entity unless the consent is actually kind of provided. So that's really one of the core parts of the mission. The second part of the mission is actually to kind of help generate what we call as aggregated data, primarily with the interest for policymakers. So we want it to be completely privacy preserving, but we would like the ecosystem to have significant amount of health data. So think of it as data on what medications, what procedures, what diagnostic tests were run, say how many were outside the normal range, broken up by certain age groups and genders and so on, but being available, for geographies. This is going to be really powerful for India going forward as it kind of looks at how to do, epidemic tracking or just to decide where to put the next healthcare facility and so on. The last part of the mission actually doesn't just focus on health data, but I just want to step back, and while we're on the health data topic, I think very well pointed out that governance is going to be quite key. There's already in India, as this has been announced, and it's been announced by the Prime Minister, there is a reasonable amount of polarization between people who have fear about, hey, all this thing is actually going to lead to my data going into the wrong hands, versus a whole bunch of people lauding the effort, saying, hey, this is really good for the system. And so I think in many ways, those debates are still out. And part of the reason why these debates occur is because India still lacks the appropriate legislative form. So, India has been working on something called the data privacy bill, but the data privacy bill is still pending in Parliament. We haven't really passed it yet. And so clearly coming up with a health data mission at this point, when the overarching privacy laws are still not yet in place, kind of puts a big question mark, especially if there's a low trust in government and government systems, it does put a kind of a challenge on it. A couple of other things that the mission does, and I'll just talk about it briefly before we wind up and my part of the talk, is that the mission also looks to kind of standardize two other things, I think, which are very important from a UHC perspective. Number one is on actually health claim processing. So India actually only does inpatient claims, and the whole process is very inefficient, extremely expensive because it's mostly manual. And essentially, if you have to really get to UHC, you need a way by which you can actually process OPD claims, medication-related reimbursements at very, very high volume, very low cost for a country like India. And I think one of the things that we are trying to do in the mission is to actually put that digital rails and get everybody in the existing ecosystem on it far before actually, I think, those reimbursements kind of come into play. The second thing is actually on standardizing what we call as bringing interoperability to digital health services. Services like teleconsultations or being able to book a home medication, home diagnostic request, and so on. One of the things that the mission is doing is actually prescribing what we call as open protocols or standardized protocols, which can be implemented by any software provider. So imagine that I'm running a hospital, or I'm a doctor, I'm running a small clinic. I can choose any software I want to handle my digital interactions, like booking appointments with me or handling my teleconsultations, and the consumer can have any mobile app that they want. And India is huge on the smartphone side, with one of the lowest data costs in the world compared to what we heard from some other countries. And it's a very good thriving ecosystem of people building services on the mobile phones. So we really want to kind of create this ecosystem for innovation, where a whole bunch of digital health services, and specifically helping add to the access side of UHC, can be driven by the mission. So very interesting point, I would say, in India's journey in terms of what we are taking. So I think while many things that India is doing in the mission is probably very specific to its local requirements, we are borrowing from as much as we can from many of the learnings from the West, especially countries that have done it. So almost all of the standards that we've picked, whether it is FHIR or whether it's NOMED CT or whether it's LOINC, there's absolutely nothing that we are trying to replicate. We're just copying and pasting things that we know are mature and it works, but on other things, especially in terms of the use of digital consents and how we actually have federated data stores to enable and democratize data, I think that's quite unique to how India is approaching it. I think I'll end with the fact that at this point, if you were to come to India, you will find just as the COVID, I think we hope that there is no third wave in COVID. This new national initiative has really pumped in a lot of new energy and enthusiasm, especially among healthcare and health tech providers. So while I think streamlining of health data is going to be super important for UHC, I think what we are seeing in India is just like the first early steps. Of course, this one results are going to be out, but if you look at other journeys that India has done with other digital public goods, especially in financial inclusion or with identity, I think India is kind of taking a similar strategy now in health. Thank you.
Thank you very much, Kiran. It's very interesting that you mentioned that the mission essentially is working on these digital building blocks, and yet we have this big federated sort of data structure and approach to that. How are sort of these different states and the state actors involved in making the systems more interoperable, because India is so diverse and there's so much heterogeneity in how states approach policies. So how is that, all of that coming together?
Yeah, so I think the idea was to kind of provide freedom to every participant, right? So the mission does not prescribe. So let's say you are running the mother and child program in a state, and we do not prescribe, hey, what software you want to use or how you want to have your processes within your mother and child program, right? So we want you to have that independence. All we are saying is, hey, can you think of what is the health information that you are holding that would be important for that mother or the child in the continuum of care? And can you make sure that you start sharing that with the mother and the child by linking it with their health ID, right? And when you share it, also share it in a format that is standardized and machine readable so that systems can then use it for analytics or analysis, right? So by keeping our boundaries to what we think would be significant value to the individual, and we are able to kind of convince pretty much anybody, whether it's in the private sector or in the public sector, to say that this is good for the overall ecosystem if you participate. And I think at least that's where we are. So that's why I said there is a kind of a strong support and enthusiasm at this point within India for this.
Okay, great. Just to quickly add to that, so of course, the freedom is necessary for each individual actor to sort of understand what is it that they need and tailor their measures according to that. But also, if you want to achieve this population level aggregated measures, you need to have some sort of harmonization between different regions and areas. So I think that's also the next challenge that is there. Thank you very much again, Kiran. We will now move on to our final speaker, which is Eileen Tuzel from Pfizer.
Thank you very much, Professor Shaikh, and many thanks for the World Health Summit to include me into this conversation. It is a very interesting panel. I very much learned listening to the panelists. Many thanks. I truly believe that constant evolving healthcare with its technology, data, and digital capabilities must deliver better healthcare solutions for worldwide and for people everywhere. And we are already on our way towards this, be it in patient care, be it in delivering of medicines, or also in pharma supply chain. But when I listen to the other panelists, there are some very important matters, very important issues that digitalization gives us hope that we can solve, hopefully in the next round, right, like creating common data space, right, like connecting private and public sectors, providing information platforms, creating those digital tools that can create access and strengthen healthcare for everyone, and also better targeted therapies. We are on a good way, and I hope that I can just convey what has been accomplished in the pharma with two fascinating projects that I think are going to give some examples on digital projects. One of the projects is called Atlas, which stands for Antimicrobial Testing, Leadership and Surveillance, which is actually dealing with AMR, the antimicrobial resistance, across the world. The fight against AMR has been one of the focus for global policy, but also for public health. And still, 700,000 patients die from resistant infections each year. Regarding AMR, there are many problems and many solutions to fight against, like creating AMR programs in the countries, more targeted therapies, higher vaccination rates, better access to medicine, but also incentives for research and development for new agents. So the project Atlas has been initiated in 2004 to actually initiate a monitoring, real-time, to monitor the real-time changes in pathogens and their resistance, and to create knowledge with the certain resistant bacterial infections that tend to occur, where they are, and also which antibiotics are still effective against them. So this was the idea of this project, was to actually create an environment where appropriate use of antibiotic therapy was enabled across the world. What was so fascinating is that this project has gone on for 14 years and across 73 countries and 760 sites with data of more than 500,000 isolates. And of course, this is a tremendous data that was created, a platform that was shared. And this is a publicly reported findings of the surveillance program that was also shared in more than 50 publications and 750 medical congress presentations. And the hope was always to better usage of antibiotics for a sustainable healthcare in infectious diseases. This is just one example of how we can share data and collectively create platforms within the countries for the use of public, and how we can further create digital networks to continue the discussion for such important problems. Another project that I also would like to mention is how we can utilize the technology to bring the product to the last mile for a better access or better coverage for the emergency products. Since 2019, we have been working together with Zipline to leverage the power of drone technology to strengthen systems, but also to expand the access for more important emergency products to the last mile. The drone delivery system has been a massive step in Ghana to realize the ambition of the Ghana government for the universal health coverage, but also a good example for a public-private partnership. Zipline drones today are delivering nearly 150 essential medicines, emergency products, including blood, vaccines, and many other essential and emergency medicines to an estimated of 2,500 healthcare facilities in Ghana, and hopefully reaching to 15 million citizens in the rural areas. We are very hopeful with the learnings of this program because we think that this is a good example where we can utilize more of this technology to deliver important emergent vaccines and also other forms of medicines around the world. These two projects are underlying how it is important to bring the silo approach to an end, where collaborations and public-private collaborations, country collaborations will help to utilize these digital technologies for the better outcome for the healthcare facilities. And with this, I would like to end the value that is created to focus on solving the problems, issues, rather than generating digital technologies that are not used, but to really focus on our efforts on really specific problems to solve for the future. Thank you.
Thank you very much, Eileen. One of the questions I have is about the AMR project that you mentioned. Now, you mentioned that you generated hundreds of thousands of data points through that, right? And people are often skeptical about, the private sector and the data privacy concerns around that. So how did you ensure, that there's this, who basically owns this data and what happens with this data? Because I think we heard one of the speakers also mention that, the person that generates the data owns the data, right? So how did you sort of ensure this?
Thank you for the question. So we don't own the data. So this is an alliance. Atlas was a project that was that was an alliance, that was a collaboration between not only Pfizer was among that, but other pharma companies as well. So nobody owns the data. It is the alliance that owns the data, and it is publicly available. If you go through the net, you will see that it is there and publicly available data.
Mm-hmm. Thank you very much. So now that we have the 5 speakers, have their opening statements and some discussion as well, I will move on to audience questions. If you have anything, we also have some questions online. But if anyone has any thoughts or any comments to make. Yes.
If he's perfect and no mask.
No mask?
Yeah,
not touch you. Thank you. Yeah. My name is Said. I work for the UN Agency for Palestine Refugees. We cover the 5.7 million Palestine refugees in the 5 different places. And we have an EMR covering all the 140 clinics with the 3 million patient records, which is good. But my question, I have 2 questions. One is the quality of data, which includes the accuracy and the completeness. We discussed, we have metadata, meta-analysis, but what we learned in our data set is not as accurate as we wish, and is not as complete as we wish. And then to avoid the garbage in, garbage out, that we have a lots of struggle how to make sure that the people enter correct data. And if you can share any approach to how to make sure, say, for example, OECD, how we can make sure the data in the EMR are accurate and comparable. I think that's the biggest challenge. Second one is the access to the services outside the domain. Say like in Palestine refugees that we try to get, we have lots of offer from the US and Europe how to provide a digitalized telemedicine care to the mental health, everything. We struggle that it was very good, but what we struggle is how we can legitimate such services to record that the services are outside our domain. And then that recording to our EMR, our legal people flatly say no, because they are not responsible for our people. So my feeling is that the digital health and universal health, UHC, that this could reach to the access to the existing services within the domain, but we have lots of things to do, go beyond the existing services and generate the new services. Thank you very much.
Thank you. So I guess anyone is welcome to take on the questions. Francesca, would you like to?
I'll start. It's actually still a huge challenge even for OECD countries, the issues of the quality of the data, the standardizations of the data that go into the electronic medical record. So there's definitely an area where lots of improvements needs to be made, starting with having a common standard data terminology. So terminology and also having common standards for data sharing. So, it's something actually that is paradoxically more difficult for countries that have already maybe gone a little bit down the road, but started the wrong way without having, standard terminologies and data sharing standards. So if you are starting from the beginning, I would definitely say that's something to build from the start, that you have some common standard way of entering the data and then the information. There are efforts that are going on in countries even to try to map the data to common data models so that they can then be shared even in a federated and decentralized way, by having also researcher making queries, by having data which are mapped to a common data models. And I think, the huge efforts in standardizing data terminology and having standard for data exchange, it really creates that global public goods that I think one of the speaker was referring to, because it then creates a sort of a marketplace where different actors can obviously, then work and making sure that they can be used for analytics, for even creation of software and so forth. But it creates also space for collaborations within and across countries. So I don't have really the magic solutions. It's something that, but one thing that I would say is that the standard terminologies, it's something to work on from the beginning. If you want, you can get in touch. We can point you to some countries that are a little bit more advanced on that.
Thank you. Nanjira.
I think there's a very important element that the gentleman brought up, and so even at the data collection point, where we have to recall that the political aspects to the societies and the trust, power dynamics that exist can absolutely determine whether somebody deliberately gives you, sort of like obfuscation information. And there we understand something. The political reality there could be that refugees, and it could vary across different communities, use obfuscation as a survival tactic, much in the same way some of us will game how we do our search on Google or elsewhere because we know what kind of machinery is behind that. So there are political determinants and social cultural determinants, which bring up the question, are you the right person to be collecting that data? People might be wondering, will you be here tomorrow once you've already collected that data? What's the guarantee that this will continually improve upon my health and even other outcomes in life? It's one thing if the only available tool for digital or data elements is health, and you're not getting that for your social or, keeping in touch with families. That's what I was speaking about earlier, that whole ecosystem approach. It's not enough to just take a narrow technical view to areas, especially where we're intervening in social, cultural, and socioeconomic and social political realities. And those are the real other invisible, intangible determinants that Francesca spoke about earlier, that can, right before we get to you can have the perfect technical system designed based on all the recommendations, but that element of trust, an element of whether people feel they're always at risk, will determine whether or not they even provide any kind of quality data or even show up to access digital health solutions based on those determinants that we must never forget.
Just to add to that, I think that something that's always missing is that education in terms of the people collecting the data. Oftentimes, they don't see the entire picture. They don't understand what data they're collecting, what the data is going to be used for. The people giving the data don't also know. So I think something we've realized is that there needs to be an education of the entire ecosystem such that, and this is now pointing towards data as a public good. If people realize that the data that they're giving or the data that they're collecting is to improve the general community, the population, and the system itself, then most likely they would put a little bit more effort into giving good data. So you give a health worker a form or a phone to collect data, and he doesn't know what, as far as he's concerned, it's just, you've just added one layer of additional work to his schedule. But if he knows that, okay, potentially this data could help improve the system, or even make his work easier in helping design a tool that will make data collection easier, then that might be helpful. So I think, it steps back to how do we ensure that the entire ecosystem is digitally literate and they see the entire picture, not just a piece of the pie, so that they know that their contribution to the system is actually very important in helping us develop, a sustainable healthcare system and, using data.
Thank you very much. So this answered already one of the questions we had online, which was about, you need people to collect the data and you need trained people to collect that data. So how do you ensure that, they receive the adequate level of skill? And that goes back to what Kiran already mentioned before, that whoever is, in a way, collecting this data and holding on to this data also needs to be a part of the mission that you're talking about, needs to understand why this is being collected and what is going to be the use of this and how it is going to benefit the people. There is a question online, which is, should local governments be trusted with medical data if there partly is a high level of corruption, and this might just feed them, one more thing to sell to the highest bidder? And this is something which Kiran pointed out as well about, people already have a fear of what is going to happen to their data, especially in, systems or in countries where there's a lot of sort of divides in society. And how can you possibly address such fears about, what their data is going to be used for? And then, of course, that also brings back to the point of accuracy of data. Are people, giving you the right kind of data? So, Kiran, would you like to address that?
Yeah, sure. And I think, ultimately it's going to go back to governance and what the country is going to really do on the governance of data. So I think the way at least India is going, and I think, it was interesting that we were using the word ownership. So India is kind of taking this position that, because if, let's say, the doctor can say, hey, I wrote this prescription, so this is my data. The patient can say, it's about me, it's my data. So India actually sidesteps this question of who owns the data and instead starts to just say, if my data is being held by that clinic or by that doctor, then that doctor has to offer me a whole bunch of rights, especially on how they actually store, use, or process that data. And one of the interesting things that India has done is that it recognizes the idea that I can provide a consent for certain uses of my data. So, and that consent itself can be a completely electronic defined thing. So India has defined actually a technology framework for actually consent management for these kind of things. And the consent is very, very specific. There's got to be a purpose for it. There has to be what data are you getting kind of seeking access, how long can you have access to it? And it also allows these consents to be collected by organizations that are being created in India called consent managers. So essentially it's like this: when I get a health ID in the Indian context, I also choose a consent manager. And it's really that marriage that keeps my control over my health data. So it allows for me to now register and say, okay, I am willing to share my data and my health data to this organization for this purpose. And it also allows me to change my mind and say, hey, I think I changed my mind. I would like to, redact that consent. And so it's a very interesting new phase we are working with. But of course, the questions still remain, as we think about digital literacy. India has people who are everything from illiterate without any phones to, people who are probably very intellectual and really not very different from somebody from the OECD. So the question is, can this system that we are trying to bring about for a large country like India, how do people kind of become digitally literate, understand their rights, start acting on some of these structures that we're given? And specifically, the questions are going to be about what is the role of the government, what's the role of, say, community and society, and what's the role, say, for various actors in this ecosystem to make sure that we have a thriving system and a safe system actually for use of health data. So I think those are going to be very interesting things that we will try to answer over the next few years. But anyway, that's the direction that we are going at least on health data here.
Yeah, and I think it's very important, at least in the context of India, because the level of, literacy in general is low. So are people even going to read the fine print of, somewhere at the back of a page in a footnote of what their data is going to be used for, how long it is going to be used for? So it's, of course, it's up to the people to, sort of increase their literacy, digital literacy and so on, but it's also up to the government to put all this out there in a very transparent manner, that it's not somewhere, embedded at the back of a booklet or something, but right up front where people can immediately read and consent to that. So yeah, that's very important. Thank you. There is another question online, which is, who should be in charge of data storage and distribution? Speaking of backend infrastructure, security, digital governance. And I would like to ask Eileen, because you've collected so much data, and do you have any thoughts on how you manage this? Who was responsible? How did you liaise with the country governments in terms of who's going to manage and the distribution and storage of all this data in your project?
So many thanks. So for the Atlas project, the distribution and the ownership of the data was belonging to the project managers, let's say, the healthcare facilities who were contributing to that project. For us in the healthcare sector, it is always the one who generates the data is the owner of the data. So all those hospitals, the project owners in the science sector, who are actually creating that data, and usually are the owners who are disseminating that data as well effectively. So pharma sector is always in collaboration with the hospitals, and also all those data, the creators of those projects and and the programs, so that we are not actually at all in any ownership of most of the data that is being provided. For us, what is important, and I really like the conversation where I think what is important is to actually leave the ground to those who are actually doing the job, to make them, to enable them to collect the accurate data and to have the regulated, standardized, and probably also corrected, or in a way confirmed data that is going to be much more valuable for us, rather than to collect, to create a ground where everything is garbage in, garbage out, as we were saying in the panel discussion previously. So the owners should be always the ones who are actually know the purpose, create that data for a strong purpose for them. So that's why, in our opinion, it is just to leave it to the right hands, and then see how we can collaborate further with the outcomes for a better healthcare.
Mm-hmm. Thank you, Eileen. Yes, we have a question in the audience. Actually, we've got 3 questions, so we need to rush now. Can we go to the lady at the back first?
No.
Good morning, and thank you to the discussants. It's been a very interesting discussion. My name is Dr. Adezo Okonkwo from the Federal Ministry of Health, Nigeria. And I just want to put out something, what I call fragmentation of digitalization. And that happens a lot in our facilities. You go to a facility and you see a healthcare worker with like 6 different devices, all for different programs. And that overburdens them. And because they don't know what's happening, they don't know what the data is going to be used for. It also gives rise to the likelihood of even more, the quality of the data even being reduced, because they still have to write back up, on the paper. And so I think we need to think through how we're going to start integrating these processes. And let me just see if we can get some thoughts on how we can start to integrate these processes so that you reduce the burden on the healthcare workers, which is a very serious issue. Thank you.
So we'll take the second question as well. So we have both of them and then we can answer them together. No, this gentleman was first, sorry.
All right. Thank you very much. Excellent insights from everyone today. My name is Dr. Peter Kamunyo. I work for NHIF in Kenya. That's the National Hospital Insurance Fund in Kenya. And we're in the process of scaling up to get to UHC. And one of the key things that we're doing is the digitization. And we have started the process through biometric registration and e-claims. Now, when it comes to UHC, and I like the points that Jide brought on, which is the demand side financing, because healthcare costs, and the biggest issue we have is how to raise the funds sustainably. So how can we use, number one, technology to ensure that there's also transparency and accountability in the funds that have been raised? And secondly, because like what we're doing is we are about to enact a law that everybody who can pay to pay, and those who cannot pay to be identified and supported. So the identification of indigents, something that is very fluid, it's very dynamic, keeps changing year in, year out. How do we ensure that that is sustained? And then finally, on telemedicine, as Francesca was saying, there are soft issues. And in our experiences, the technology is there, the personnel are there, but the issue is the patients themselves utilizing that. How do we ensure that we are able to address those cultural issues? Because patients still want to be touched by the doctor. How do we cross that gap, especially right now that with the motivation of with COVID and moving towards more technology? Thank you very much.
Thank you very much. We are really close to being up with time, but any final thoughts that you have on that? Yeah.
Okay, I'll quickly try to address the question from my colleague in Nigeria. Yeah. So I think this is where the government really has to take ownership. And, we're going to highlight this in our report, which is going to be launched very soon. But really, the government should be responsible for regulating healthcare and bringing together public and private. What you said definitely is what is happening, where you have so many donors, so many different fragmented programs, so many different initiatives, all within, a very small space, and it's creating duplication. So is there a way to align behind core values, core principles, core methodologies, interoperability, system coding, a common language between all the different players, such that digital transformation can happen? So I'm glad you're from the Federal Ministry of Health, because I think that you play a very key role. In fact, we are going to come to you with that report to see how you can already begin to adopt some of the recommendations and cascade it down, because without the federal government, I don't think that, if you don't play your role, which is a very strong role in bringing together public and private and governing, providing that governance, we're not going to get to UHC.
So thank you very much, Njide, and we are really out of time. So I have been instructed that we have to wrap up, but if you have one quick.
Just a quick word to my fellow country person.
Yeah,
It's only fair. No amount of tech will bypass all the issues that have predated NHIF or any other kind of government insurance scheme. And those are the things that are hindering all the interventions. So following the upstream to make sure that that does not undermine what could be the potential of what technologies are introduced is a political question.
Thank you very much. Just quick key takeaways. I think this has been a very, very engaging and lively discussion. There is no digitally strong health system. Everybody is trying to get there. Digital divides are real. They can take several forms, in access, gendered forms. We need to ensure access to basic infrastructure like electricity before even thinking about providing people with laptops and mobile phones. And whoever owns the data, whoever is collecting the data, especially healthcare workers, need to be on board with the mission that we're talking about. So these are some of my key takeaways. I'm sure you've had more. Thank you very much again for this brilliant panel. Thank you to our speakers. Thanks.
Thank you.